Man presented, who's a tailor by occupation, presented with an ulcer over the left leg for last 15 years. Patient gives a history of a swelling in the left leg for last 15 years, which was gradually progressive in size, and spontaneously it ulcerated and became an ulcer proliferative growth. Patient gives no history of any smoking or any alcohol intake. There is no history of high risk behavior, sir. Sir, on examination, patient was examined in a well-lit room after taking informed consent. In, and informed consent for videography was also taken. Karnofsky's score is 90. Patient is is well nourished and well hydrated. His vitals are within normal limits. Upon examination of the lower limb, there is no apparent lengthening or shortening of the limbs, and the left limb is the patient is lying comfortably on the couch with extended legs. There is an also proliferative growth of size of 3 into 4 centimeters in the left leg, 2 centimeters below the knee joint. It has dilated veins present all around. The margins are necrotic, edges are everted, and there is slough on the floor. There is induration extending beyond the margins of the ulcer, and the base is formed by the underlying muscle, sir.
Is there any muscle here?
Bone, sir.
Yeah. Underlying soft tissue and bone is easier to say. Yeah,
so there is no distal neurovascular deficit. Sir, on the contralateral limb, there is a swelling present of size 3 to 4 centimeters medially, which is also 2 centimeters inferior to the knee joint. It is side to side mobility is present, and slip sign is also positive.
What is the consistency?
So yes, sir. So it is soft to firm in consistency, sir.
Now, if I was to do the fluctuation in this, it will be better I flex the knee and this becomes more and more free. Can you see that? First of all, I don't think it is soft. It's on the firmer side. But yes, you can see some lobulations on the surface. You see carefully, right? And it is freely mobile in both the axes. He's calling this the slip sign, right? Which is usually suggestive of lipoma. You know that? Slip sign is lipoma usually. It may not be, so we need to be careful about the changes that may happen in lipoma. Okay? Now, if you want to do fluctuation, you need to stabilize the swelling always. And then you can do with this method. One is this is the observing finger, this is the active arm. But you need to fix it. Okay, the other one is fix with the same and try to do with this is the active finger, this is the observing. Similarly here. See that? So even the fat at body temperature is also more or less liquid. That's why some confusion can happen. And in lipoma you get what is called a pseudo fluctuation therefore. What do you call?
Pseudo fluctuation.
Because it is false. In a classical fluid-filled swelling, you will get a true fluctuation. But in a lipoma, you get a pseudo fluctuation because fat at body temperature may behave like a liquid. Not that it is liquid, but it may behave. Clear? Yes. But the other thing which you need to look for when you say fluctuation is positive is trans-elimination, which would prove it right or wrong. Okay? Now for that you need to switch off the light. You know? See that?
Yes.
So it is brilliantly transluminant. And it works as an ultrasound. You can see some solid part also. The best thing is switch it off, switch it on, switch it off, switch it on, switch it off. Then your eyes get conditioned. So this is liquid, fluid. So we're not looking at anything nasty. So all clinical tests are relevant. Really pay importance. Switch on the lights, please. Now back to this, he described it reasonably well. It is the only thing I would like to emphasize, it is whether it's fixed to the deeper structures or not. And he mentioned that it is ulceroproliferative. So it was a swelling which has opened up. So the edges are everted. He's right. This is the edge. You can see this? Everted. Okay. And next he mentioned the induration is extending beyond the boundaries of the ulcer, which is more a feature of malignancy than inflammation, because inflammation also produces induration. Induration is some sort of fibrosis, which happens in inflammation also. So how would the two be different? Induration due to inflammation versus induration due to malignancy. One, tenderness. In inflammation induced induration there is tenderness, and in malignancy induced induration it generally goes beyond the boundaries. So because it's more of infiltration. You understand the difference? Yes. Okay. So he says there are dilated veins here, which we would appreciate more in the standing position, but I agree with them. So this is important, because if this was lower down, you would think of a varicose ulcer which has undergone a malignant change. It is not looking like a benign swelling. Why is it not a benign swelling, Shagun?
So the margins are necrotic.
No. Why is
The
it?
points in history and points in examination.
Right.
Points in history are that the age of the patient, he's an elderly patient. There is no history of trauma. There is no other history suggestive of inflammatory or infective lesion. And then there are points on examination. It's
In history, it has grown rapidly, and it is ulcerated. A swelling which was
Short history.
It was a short history.
with rapid
Elder
progression.
patient, older patient, rapid progression, and ulceration. They all go in favor of malignant change in a swelling. Then on examination, induration
The
extending
induration,
beyond,
margins of lesion,
also the
ulcer
everted
proliferative
edges,
growth, everted edges.
and you can see some bit of bleeding happening. Can you see the blood spots all around? I won't cause it, but you can see around that it has gone and produced that kind of a picture. Okay? And then areas which are undergoing the change. So what is the likely diagnosis here? Which is a skin lesion, malignancy with everted edges commonly seen on the skin?
Squamous cell.
Squamous cell carcinoma. So it is a malignant lesion involving the left leg below the knee, most likely in an elderly gentleman. So 60, how old is your patient?
It's 60 years.
No, he's more than that. 70-year-old gentleman with an ulceroproliferative growth involving the left upper leg, most likely malignant, probably squamous cell carcinoma of the left leg. And how I'm going to approach any lesion which is malignant? One, investigations. Two,
To
Confirm
confirm
the-
and support the diagnosis, to stage the disease and to treat the patient.
so to confirm the diagnosis, I'll take an edge biopsy. And look at this. Where would I take the biopsy from? Please remember what I'm saying. You will not get to see practically. From the edge. Because edge is where the maximum proliferation is happening. Don't take it from the center. It's a necrosed part. Second thing, if you take a wedge, you get some normal tissue, and the pathologist is able to look for the extent to which ATP are visible. We can get you a good idea of the margin. Okay? So edge biopsy, which is an incisional biopsy from the most proliferating part, which is the edge. This is a necrosed part, so don't go to the center. That's number one. I'd like to do imaging. Before that, simple X-ray, including following the rule of two. Two is two sides, two joints, two views. Repeat.
Two sides, two joints, and two views.
The joints would be included both knee and ankle. Two views, AP lateral. Two sides is to compare with the other side, which is more relevant in children, of course, where the ununited epiphyses, etc., are present. So you can actually use it. Now, this picture is quite suggestive of malignancy. So we may need a specific investigation to get an idea of the soft tissue. You don't need to necessarily do MRI and CT in all the cases. That's what I want to highlight. Clear? What is missing in the examination so far?
Inguinal lymph node
The
examination.
regional lymph node examination. They are hard superficial group of lymph nodes You can't miss this node, no? Give me a marker. थोड़ा निशान लगा रहे बाबा जी, है ना?
जी कोई
दिक्कत हो तो मुझे बता दीजिए।
नहीं
थोड़ा इसको रिकॉर्ड कर रहे हैं, मेरा ख्याल आपको एतराज नहीं होगा,
नहीं
क्योंकि सबको बताना भी ज़रूरी होता है। ये सब लोग सर्जन्स हैं, डॉक्टर्स हैं, ठीक है। एक नोड यहाँ, वन हियर। Very surprised if he doesn't have lymph nodes. If somebody tells me no lymph nodes palpable, I'll be very, very concerned. Now, thank you, Babaji, धन्यवाद. So, we will plan ultrasound of the pelvis and inguinal region to look for any lymph nodes. Don't be a theoretician, you will never learn anything. If you can't palpate the inguinal lymph nodes, which are the easiest to palpate, there will be a problem. So now the plan would be, once you've done the imaging, wide local excision, which is taking a margin of 1.5 to 2 centimeter, going deep, three-dimensional clearance. And based on what our observation in imaging is, we'll go deep. And usually we'll shave off the bone. Bone is not involved in clinically. But in imaging, we need to establish that. That's why MRI will become important. And ultrasound of the lymph nodes would establish. Some people would like to do an FNAC of the lymph node also to confirm it, but do it image guided. Once that is done, our treatment is wide local excision of the primary along with ilioinguinal block dissection. You will mark the incision based on the inguinal ligament, and there are various incisions available. You can watch my YouTube video on ilioinguinal block dissection. I don't need to waste time there. But usually we take a lazy edge to cover up for the flap necrosis, so that it doesn't happen. And this is the iliac extension, which we'll do based on the findings of the tip of, this is the antispheric spine, pubic tubercle, and this is the lymph node. This is where the femoral is palpable, so we don't expose the femoral to, we take a lazy S here. This is the incision that we fancy. The lateral limit is sartorius, medial limit is erector longus. That's the inguinal ligament. And the upper limit here is bifurcation of the common iliacs. And genitofemoral is the lateral limit. And depth is octator now. That's the resection. Local excision here, and this would not be covered primarily. You can see that lesion. But this would, skin won't come automatically, so we need to use a flap. We can use a sartorius flap, which is based on taking the sartorius from here. This is sartorius. You can rotate and put it here, or you can use free flaps. There are various options.
So also the skin looks involved here. So
and if the skin looks involved, the margin would be wider. See that? This is discharge coming through, but we'll have to establish that on imaging. Marker then. This also doesn't look all right. So we'll need to keep that option also with us. So we need to excise, reconstruct, block dissection, and follow it up with adjuvant radiotherapy. Any questions?
Sir, would it matter where we take the edge biopsy from in this patient, whether the proximal margin or the distal margin?
It doesn't matter, but it should be the edge, not the margin. So we'll take it from here because I see proliferation here. I can take it from here also because this is not going to extend my margin in an impossible area, but preferably on this side because the distal you're away from the joint, but it doesn't really matter here. I can take it from this spot or even from here. I'll take an edge or a wedge perhaps.